Hi everyone, this is Carrie Dillon from class of 2019. In this video, I will be discussing tuberculosis. We'll go over something with what tuberculosis is, prognosis and treatments, and some other helpful buzzwords that will help you for the test. We'll first talk about the bacteria itself, Mycobacterium tuberculosis. It's a member of the genus Mycobacterium. It includes some other species, including MAC. I'm sure you've heard this one before with dealing with AIDS patients and HIV, and then leprosy as well, which is a part of that genus. All of these are non-motile. They're acid-fast bacilli. They are obligate aerobe, so therefore you'll see them in tissue that requires a lot of oxygenation. So the lungs, for example, in particular the upper lobes of the lungs, because that's where most of the oxygen is going to. And they are transmitted through inhalation, so that's inhalation of the bacteria. So that's going to be important when it comes to respiratory isolation for somebody who has this disease. Of note that this might come up is that the bacteria contains cord factor. And what this is it actually helps with virulence, and it creates a serpentine cord that you can find sometimes on the cultures itself. They might ask about virulence factors in there, and cord factor is one of those. It is very slow growing. Oftentimes, it's difficult to actually get a culture, and that is the one way to definitively to be able to definitively diagnose tuberculosis. Other ways that they'll often use is an acid-fast bacilli smear. They may also do nucleic acid amplification, and we'll talk about those a little bit later with diagnosis. Symptoms are fairly nonspecific, with fevers and night sweats and weight loss. Cough you'll often see in the vignette of if they're giving you an easy answer, they're going to include hemoptysis, but you can have tuberculosis without hemoptysis, so just keep that in mind. There are several different pathways that pulmonary tuberculosis can proceed. This slide kind of is talking about a couple of those, and we'll go over each of these in more detail. But someone who gets primary tuberculosis, the vast majority of those individuals will either kill off the bacteria, or they'll have latent infection. And someone with latent infection may never have a reactivation. The ones that do, it can take years, sometimes decades, for them to have a reactivation and move on to secondary tuberculosis. And from there, they can either once again get treated and and have that healed, or move on to localized lung destruction. Minority of patients with primary tuberculosis, the 5 to 10% you see up there, typically your immunocompromised patients, those that are on immunotherapies, or your HIV patients, they can move on to progressive primary tuberculosis, which can stay in the lungs and become progressive lung disease, or can actually spread systemically, bacteremia, and turn into miliary tuberculosis, and that can affect different organs, and we'll talk about that in a little bit. For primary tuberculosis, it's often mild, asymptomatic, it's a subacute, and what happens is, buzzwords that you're going to have is your GON complex. That's and you'll see the two pictures here. I had the hilar nodes plus the GON focus. And what a GON focus is, a calcified caseating granuloma. It's usually subpleural, but these two things more or less equal a GON complex. And here's what that kind of looks like on a chest x-ray. This heals by fibrosis encapsulation and become that latent infection that we talked about. And patients with primary tuberculosis will be PPD positive, and they will remain PPD positive because that will not go away. We discussed of latent infection can move on to reactivation into secondary tuberculosis, and this can be due to immune response. One common one that you'll see is somebody who is taking TNF-alpha inhibitors, and part of the process before you patient starts taking TNF-alpha inhibitors is to actually get a PPD or a quantiferum to ensure that they do not have tuberculosis, because it often leads to this reactivation. And what you're going to see here is a caseating granuloma with central necrosis. And you can see Langerhans cells with that. And it's going to be typically found in that upper lobe because like we talked about, since they're obligate aerobes, they're going to prefer those tissue with lots of oxygen in them. There will be no lymph node involvement, and that will help you distinguish between primary tuberculosis. Secondary tuberculosis and primary tuberculosis, the presenting symptoms are pretty similar, so that's going to be, you will not be able to distinguish between those two very well with the symptoms only, so a chest x-ray is going to be important for this. The one that we saw before with the different pathways you can have with the disease, we talked about miliary tuberculosis, and this is if the bacteria spreads to the bloodstream. Once again, the symptoms are going to be pretty similar, at least in the pulmonary area where it's going to be subacute or chronic. But other things you might see is failure to thrive, fever of unknown origin, or organ dysfunction. Because you can see on the left-hand side here, the extrapulmonary tuberculosis, it affects almost every single organ. One that's not on here is the liver, but it can also affect the liver as well. Of note, bones and joints of the spine, that's going to be called Pott's disease. You might see that somewhere, or at least that's one of the buzzwords. Your chest x-ray is going to be a little bit different than what we saw before with the Gone focus. You're going to have a faint reticular nodular infiltrate, so basically these little tiny dots that you'll see everywhere, and that's going to be a uniform distribution bilaterally. You can see it pretty well in the chest x-ray, sometimes non-specific with the imaging, and oftentimes they'll get a CT as well for just a little bit more specificity. And this is an example of what you might see on miliary tuberculosis. They did choose to get a CT scan. PPD is something that you're probably familiar with, and most likely you've had one of these before. You want to know your PPD criteria. Remember, that's going to be after 48 to 72 hours. And it's important to remember that it's in duration, not just redness. So how large that in duration is. You can read these here, but 15 millimeters is for basically any healthy individual, as long as they're age 4 and older. 10 is the in-between with young children, people in healthcare, working in healthcare facilities or prison, foreign-born individuals, any individual with chronic disease that's associated with increased risk. And then that 5 millimeters is set for people with HIV infections, if you have close contact like family members with an active infection, and anybody immunosuppressed, so if they're on immunosuppressive medications, things along those lines. There's different routes if you get a positive PPD, so remember that if you had a past exposure, you'll still have a positive PPD. So the next step, and this might be a question you're tested on, is you're going to get a chest x-ray to help rule out current infection. If the suspicion is high with symptoms, even a negative chest x-ray might warrant active infection treatment. Diagnosis can also include positive cultures and that nucleic acid amplification and the AFB smear that I mentioned before. However, this is not necessary. If you have a high suspicion, you can still treat them as if they have an active infection. Those cultures will come from a sputum sample, sometimes from a lung biopsy, but that is usually not necessary. If they have a negative chest x-ray, therefore they have latent tuberculosis, and that's going to be treated with isoniazid for 6 to 9 months or rifampin for 4 months, and a lot of times they'll test you on those. So remember, it's actually the RIP treatment that you see with a active infection versus a latent infection. If they have a positive chest x-ray, or like we talked about this, they're symptomatic and you have a high suspicion, you assume active tuberculosis, and then it's treated with RIPE and airborne precautions. So remember, they're going to be wearing the airborne masks. You might place a patient in respiratory isolation. So RIPE is your acronym for the medications that you're going to be giving for an active infection. And those are listed here. You might be familiar with these. What I put here is mechanism and side effect for each one. Probably the most important one is INH, the isoniazid. So remember that it actually is a mycolic acid synthesis. It decreases the mycolic acid synthesis, and it requires activation by catalase peroxidase. You'll oftentimes give them B6 supplements in addition with the isoniazid because of the vitamin B6 deficiency that they might acquire because of it. And the rest of them you can read here. So in summary, the things that we talked about was the mycobacteria properties. So remember that they're acid-fast bacilli. Keep in mind that cord factor in creating that serpentine cord that you might see on culture. They might ask you a question about that. The tuberculosis progression. So remember primary versus secondary, with latent infection being the most common progression, and possibly reactivation. PPD screening, the requirements for that, in particular the sizes of the 15 versus 10 versus 5 millimeters, and that latent versus active infection. And then keep in mind your medications and the mechanisms behind those, and also some of the side effects for them that you saw on that slide earlier. Thank you very much and good luck studying.